this is a new talk. I must admit I hadn't sort of really given much consideration previously to this this particular topic. So when Nicole mentioned it, I thought this would be a great challenge to come up with an interesting talk about how the immune system and lymphomas may relate to each other. Now, if you're ever driving on foreign roads or roads overseas, this gives an example of why you might get a bit confused in terms of there's no standardised signs to tell you that a road is one way. Now, why am I mentioning this? Mainly because I think the interaction between lymphomas and the immune system is really something of a two-way street. So what I want to focus on to start with is how problems with our immune systems can actually lead to the development of lymphoma. But then secondly, how we can harness the capabilities of our immune systems to help us cure lymphomas or to treat lymphomas. So it's really a combination of those two topics that I'll focus on during today's talk. So how can problems with the immune system lead to lymphoma? Most of the time it's because there is a deficiency of the host immune system, and that in itself opens up the opportunity for lymphomas to develop. But there are some rare circumstances where the opposite is true, where in fact an overexuberant immune system, an overexuberant immune response to a foreign antigen can actually also lead to the development of lymphomas. Now, to understand this a little bit better, it really comes down to understanding this concept of what our immune systems do. And one of the important things that they do, they act as a security guard. So immune surveillance is critical for maintaining health. What our immune systems are primed to do is to be able to make a distinction between self and non-self. So to recognise what belongs to us, and our immune systems are meant to leave anything alone that it recognises belonging to us. It doesn't always happen. Autoimmune diseases are basically circumstances where our immune system accidentally starts attacking things that they're not meant to. But if our immune systems recognise something as non-self, so therefore not belonging to us, then it is primed to attack. Why this is important is we know that our own immune systems can actually help fight off lymphoma cells or other types of cancer cells when they're present in small numbers. So basically, probably day to day in all of us, the production of a cell goes wrong and an early type of cancer or lymphoma cell can develop. But our immune system can have the capacity to kill that before it progresses. So most of the time to get full-blown cancer or full-blown lymphomas, it means that that disease has found a way of escaping the immune system. So it's managed to get through the security system. And they do that by effectively cloaking themselves from our own immune system. So finding a mechanism by which they can actually make themselves completely silent. It's almost like an invisibility cloak. So we've known for a long time that disorders of the immune system can often be associated with a significant increased risk in the development of lymphomas. A classical example is that of HIV, the AIDS virus. So pleasingly these days with antiviral treatment, HIV is no longer the disease that it once was for the majority of people. But certainly for many patients, it was actually the development of lymphoma that led to the discovery of that patient actually having HIV. So that was often what we call the AIDS-defining illness, so the very first presentation with the consequences of that virus. I mentioned before about autoimmune disorders, so these are things like lupus, rheumatoid arthritis, or even celiac disease, which is an immune attack on our gut cells. All of those diseases have a very well documented increase in the likelihood of development of lymphoma during the lifespan of that particular person. Unfortunately, some people are born with congenital immune deficiencies, and that can be due to a problem that's occurred during the pregnancy, in the development of the bub, or it can be due to an inherited problem that runs through the family. And we certainly see probably 1 or 2 people per year with congenital immune deficiencies who present with lymphomas or leukemias. The treatments that we use to treat those autoimmune disorders themselves also have a chance of increasing the risk of lymphomas. So simple treatments like prednisone that we use for a range of different disorders immune suppressants like methotrexate and many others all have a defined risk of causing lymphomas. And the final entity there I've mentioned is this concept of post-transplant lymphoproliferative disorder, or PTLD. So PTLD is a type of lymphoma that develops after somebody's had an organ transplant. Now that can be the type of transplants that I do, like an autologous transplant or a donor bone marrow transplant. But people who've undertaken solid organ transplants like liver, lung, kidney, heart transplants, they can develop lymphomas as part of this PTLD spectrum. Now what we know about these disorders, they occur when the person is most immune suppressed. So when they're on the really intensive immune suppression, particularly early on after the transplant, there is this risk of developing a lymphoma. And most of these cases are due to the Epstein-Barr virus, so the glandular fever virus. 90% of the population has the glandular fever virus living with them. Most people with the glandular fever virus do not get the disease, but the virus, once it's contracted, lives with you forevermore, normally in harmony. But when we knock out your immune system, that Epstein-Barr virus can then start to replicate, and that replication can then lead to this stimulation of the immune system, and lymphomas can develop. Now, in many circumstances, for this particular disease, the best treatment is to try to get that person's immune suppression down. So trying to avoid chemotherapy, but by reducing the immune suppression, you can get the immune system to start putting the virus back in its place, and you can actually see regression of the lymphoma just simply by doing that. Now, the other question I asked before is really, can an overzealous immune system also cause lymphoma? We've been talking up until this point about deficiencies of the immune system, but in fact, an overexuberant immune system can cause lymphomas. And a classic example of this is a fairly unusual disorder called malt lymphoma. Its long name is extranodal marginal zone lymphoma of mucosal associated lymphoid tissue, and it's that last bit is the reason why we call it malt lymphomas for short. Now these are most of these diseases are driven by excessive stimulation of the immune system in response to a bacterial infection. So the most common place we see this type of lymphoma is in the stomach, where it's felt to be driven by a bacteria called Helicobacter pylori. But particularly in the west coast of the US, there's some evidence that one of the other places that can involve is the orbit of the eye. And in a proportion of patients, it's due to a chlamydia infection in the eye, leading to the same sort of problem. So Helicobacter pylori, it's a very well-known organism. It was discovered actually in Western Australia when a group of researchers over there were trying to identify the cause of peptic ulcer disease, why people get gastric and duodenal ulcers. It had always been attributed to things like a bad diet, too much alcohol. In fact, the majority of cases are due to this particular bacterium. But what's interesting is that 50% of people actually have this bacteria living in their stomach. And the vast majority of those people never get any problems from it. It just lives again, like the Epstein-Barr virus, in perfect harmony with you. But around about 10 to 20% of the population will get peptic ulcer disease throughout their lifetime, driven by this particular bacterium. And we don't understand why some people get problems and other people don't. But what we also know is up to 98% of cases of malt lymphoma of the stomach are caused by this particular bacterium. Now, this might be a little bit hard to see, but basically what happens is that the bacteria releases a chemical called lipopolysaccharide, or LPS. That then leads to damage of the local wall of the stomach, and various sort of free radicals and oxidants get released from the stomach. And then your immune system comes in very driven by the attempt to get rid of this bacteria and to fix the damage that's been caused. So important cells of our immune system are our lymphocytes, our lymphoid tissue. Now, normally when you get a reaction to a virus or a bacteria, the immune system does it in a very coordinated way. But in this circumstance, you get this massive expansion of the lymphoid tissue, and ultimately lymphoma occurs. So an example where protein stimulation within the body actually drives lymphoma. Now, most of the time, malt lymphomas are relatively indolent diseases. They're one of the low-grade types of lymphoma. But they in themselves are quite peculiar. As I say, they're almost always outside the lymph nodes. They rarely involve the lymph nodes. So the stomach, the orbit, the lung and the parotid gland, which is a salivary gland that sits up here on the side of the face. Most of the time, that site is the only place where they're found. You don't get disease anywhere else. And they are highly curable. So despite being a low-grade lymphoma, and most of the time we say low-grade lymphomas can't be cured using conventional techniques, these diseases can. Now, in about 75% of cases, if we put the person with the molt lymphoma on to eradication therapy for that Helicobacter, which is a combination of antibiotics and these things called proton pump inhibitors, the lymphoma disappears. So if you treat the bacteria, you treat the cause of the lymphoma, you can actually then get regression of the lymphoma. And this is an example of when a gastroenterologist looks down an endoscope at somebody with molt lymphoma. So the slide on the left at the top is that sort of red, lumpy sort of area, that's the molt lymphoma. And then the slide next to it is a picture of that same patient after treatment with antibiotics. And that actually is now, it's a little bit of scar tissue left behind, but essentially that lymphoma has responded just to antibiotic therapy. So, deficiencies of the immune system can cause lymphomas. Rarely, but in select circumstances, an overexuberant immune system can also cause lymphomas as well. So for the second part of the talk, I wanted to swap around, so look at the other end of the street, which is how we can try to manipulate the immune system to help maximise the damage we can do to the lymphoma. So treat the lymphoma and hopefully ultimately cure it. And this is really just the topics I wanted to work through. So we'll talk about the monoclonal antibodies. Many people in this room will have heard of Rituximab, MabThera. It's been around for a long time. It comes up recurrently in these talks that I do each year. So that's an example of a monoclonal antibody against this protein called CD20. There's a couple of new generations of those drugs, but ultimately these treatments are working by harnessing the host immune system. This new concept of biospecific antibodies, so they're like monoclonal antibodies, but even better. And then these other sort of relatively novel strategies, so immune checkpoint inhibitors, which have been in the news a lot lately outside the lymphoma space, but offering very dramatic responses in patients with melanoma and also some forms of lung cancer. So two diseases which very much deserve some form of treatment because they've been generally terrible diseases to have. And then the final sort of topic is then looking at ways that we can use our T cells, and I'll explain what T cells are, to actually also help treat lymphomas. So I've shown this slide before, but this is a good slide to look at the nomenclature for monoclonal antibodies. So the first one I'm going to look at is Rituximab. Now, so Rituximab, that XI in the middle for Rituxi, indicates it's this type of monoclonal antibody. So the pink bit is human-derived, the blue bit is mouse-derived. So the blue bit is basically the bit that binds to the CD20 molecule on our B-cell lymphoma cells. So this is a form of partially mouse monoclonal antibodies, which most of them in the early days were. Now this is the way, MabThera works in a number of different ways. Most of the way that it works though is by actually using your immune system to do the dirty work of killing the lymphoma. So when the MabThera monoclonal antibody binds to the lymphoma cell, it binds to a protein called CD20. CD20 is found on almost all B cells in the body. When it binds, it then essentially flags to your immune system that that cell is bad and kill it. So it doesn't really directly kill the lymphoma cell, it uses your immune system. And it does that in a number of different ways. It can get the body to make antibodies to attack the lymphoma cell, or it can sometimes use T cells. So T cells can actually kill the lymphoma cells directly. But most importantly, all the MabThera is really doing is pointing out to the immune system the necessity to get rid of that particular cell. I've gone over these slides before, but ultimately MabThera completely revolutionised the treatment for B-cell lymphomas. It was the single most important progress that was made in the treatment of lymphomas really to this point in time. So this was the French study that really was the first great evidence for lymphoma. This is in people with diffuse large cell lymphoma, and adding MabThera to the standard treatment of CHOP. And this is basically show that you could improve, or you could prevent 20% more patients from relapsing by adding MabThera into the mix. But more importantly, it also demonstrated that you can get 20% of people to live longer because of the MabThera treatment. So basically, that 20% of people whose lymphomas didn't relapse ultimately died of old age from other causes. So this was the first really impressive data that came out for MabThera. That study was initially in people over the age of 65, and then the MINT study came out, essentially the same study, looking at adding MabThera into a backbone of CHOP type chemotherapy in patients under the age of 65. It effectively showed the same thing, so about a 20 to 25% increase in cure rates as a consequence of just adding MabThera in. And the great thing about MabThera is very well tolerated, so it was much better tolerated than the chemotherapy backbone. Again, in low-grade lymphomas, there's an example of follicular lymphoma, taking patients treated with CHOP, adding Rituximab on top of the CHOP. And again, a 20% reduction when this study was analysed in relapse risk when added to CHOP. The same sort of data was shown for CVP. CVP is a somewhat more gentle regimen than CHOP, particularly in people as we get older. The ability to tolerate treatments like CHOP can be difficult. So sometimes we reduce the intensity of the treatment using a protocol like CVP. But it showed the same thing. Again, a 20 to 25% reduction in relapse risk when added onto a CVP backbone. Maintenance treatments now become a standard of care in follicular lymphoma. This was the original published paper from the European group that looked at adding maintenance treatment after the end of second-line therapy for follicular lymphoma. Significant overall survival advantage. So people live longer because of maintenance treatment as part of second line. Then ultimately the PRIMA study looked at the role of maintenance treatment for first line. So when you first have treatment for your follicular lymphoma, then using MabThera maintenance at that time point. And once again, it showed significant improvement in response rates and a delay in the need for more treatment by adding in Rituximab. In CLL, so fludarabine and cyclophosphamide had been regarded as the standard of care for patients with CLL up until about 2005-2006. The German study group then looked at the role of MabThera in addition to fludarabine and cyclophosphamide and found an overall survival advantage for those patients who received MabThera. And so FCR then became the standard of care for the treatment of CLL. Now, MabThera we sometimes say is yesterday's news. It is to an extent, but it still has a very important role to play. It's in fact now such an old drug that it's come off patent. So essentially, hopefully that will lead then to a cheaper version of MabThera. That will probably open up the opportunity for the government to fund MabThera in some of the current circumstances where it's not funded. So Ofatumumab is a second generation of antibody against CD20. So it binds to the same protein that MabThera does, but it binds more avidly. So it can bind even when CD20 expression on the cell is relatively low. Now that means it can work in some circumstances where MabThera won't. It also means it can work in patients who previously had MabThera and MabThera stopped working. So if we go back to this little guideline to monoclonal antibodies, so if you remember, MabThera is one of the XI ones up in the top, but Azera or Ofatumumab is fully humanised, so there's no mouse component to Ofatumumab. So that's one of the big distinctions with it. Now originally the data came from CLL. This was a group of people who essentially had no other treatment options. They were refractory to every single form of chemotherapy that had been offered to them, or they had treatment but still despite that had very large lymph nodes. So many of these patients had lymph nodes that were greater than 10 centimetres in size. So you would normally not expect a terribly great response rate in that circumstance, but this looked at using Ofatumumab just by itself. And in fact there were about a 50% response rate to Ofatumumab with very little in the way of side effects. Now very few of those patients actually got a complete response, but again, for that group, just to get any response to treatment was quite extraordinary. And so eventually this drug was trialled in people who weren't considered fit for the fludarabine type of treatment that we were talking about before. So they use chlorambucil. Chlorambucil is a simple chemotherapy tablet, pretty well tolerated by most people, and looked at the addition of ofatumumab on top of that. And it significantly improved the chances of getting a disease response. So again, now ofatumumab is funded by the government for use in CLL for patients who are unfit for fludarabine-based treatment. There's a little bit more data coming out about this drug. So rather than using rituximab on top of fludarabine and cyclophosphamide, this is a study that uses ofatumumab, and again showing quite a significant enhancement in the response. Probably not yet sufficient to say that it would replace rituximab, but the data needs a little bit more work first before they can say that for certain. So Ebenetuzumab, however, is already out there. So Ebenetuzumab is a third generation of monoclonal antibody against CD20. So it's another step up from ofatumumab. It can bind up to about 100 times more avidly than rituximab. So that's particularly important in a disease like CLL. So while CLL expresses this protein called CD20, it doesn't express it very much. So having a drug that is able to bind to CD20 at very low levels is very advantageous. And that's one of the reasons why Ebenetuzumab has been predominantly studied in CLL. Gazyva is its other name. And so once again, looking at this particular chart, Ebenetuzumab, because it's got the zoo in the middle, again, it does have a slight mouse component to the antibody, but it's almost all human-based. Why that can be important is that human beings can actually mount antibody responses to mouse-based products. Because it's a foreign animal, you can get allergic type reactions to it, which means that you can then get very severe reactions to the drug. So having a fully human type of antibody is actually quite worthwhile. This doesn't project awfully well, but if you have a look at that top chart, so the group on the left-hand side is that's the group who were treated with chlorambucil plus Gazyva. The green chart are people who were treated just with chlorambucil alone, and the blue one on the right-hand side are people who were treated with chlorambucil plus rituximab. So this study had 3 arms in it. So it was really comparing chlorambucil and rituximab or MabThera, and then chlorambucil and Gazyva. And again, it showed a very significant improvement with either drug when added on top of chlorambucil. But most importantly, when they compared the people who got Gazyva versus rituximab, the group treated with Gazyva had significantly longer responses to treatment than those who were treated with rituximab. So it looks like it is a far better drug to use in that circumstance. And so once again, the government has provided access to this particular treatment for patients with CLL who aren't considered fit for fludarabine-based treatment. Excuse me. Now, because of Gazyva's potency, it can be a little bit harder to tolerate. So MabThera is a pretty clean drug, but Gazyva, because of the amount of binding you get and the way that it then stirs up the immune system to kill the leukemia cells, means that there's about a 30 to 50% chance on the very first dose of having quite a severe reaction to the drug. Now, that always happens when you're at the hospital, so you're being well looked after at that time. But that's part of the payoff, unfortunately, with this particular drug. Because of its potency, it does have a slightly higher reaction rate than we see with MabThera. So there are other monoclonal antibodies. We use this drug occasionally in the treatment of a few diseases. So this is called Campath or Alemtuzumab. What's important about it, it binds not to CD20, but it binds to a protein called CD52. Now that's good in some ways, but also potentially a problem in that CD52 is found on B cells and T cells. So one of the side effects of this particular treatment, it essentially wipes out all of the lymphocytes in your body, which means that it's profoundly immune suppressing. So there are certain circumstances where people have been through multiple lines of treatment and nothing's working, or where they have some unusual diseases where nothing works other than this particular treatment, where we do consider the use of Campath. But infections become a very real problem with this particular drug because of how effective it is at wiping out the host immune system. Now, it's been studied a lot, so there's many, many different studies out there, but it's very rarely used. And I think that's always pretty valuable information that tells you if there's so many studies and the treatment's rarely used, it's probably a treatment that won't become part of the standard sort of treatments that we do use in lots of diseases. Now, I've mentioned a lot about T cells and B cells. And it's probably important to make the distinction between what these things do. So B cells and T cells they're both different forms of lymphocytes. There are other smaller subsets of lymphocytes other than these two things, but these make up 95% of all the lymphocytes in our body. Lymphocytes play a critical role in our immune system, our immune response to foreign bodies. So the T cells are the drivers behind what we call cell-mediated immunity. So T cells actually can directly attack bacteria, viruses. They also play a role as the generals of the immune system, so they stand back, process some of the information that's provided to them by other cells, and then work out how to best coordinate the attack against that foreign body. So it's the reason why you have all these different things. You have helper T cells, they're the generals, memory T cells. So when you've been exposed to something, the body retains memory of that exposure. It's one of the ways that vaccines work, for example, is by stimulating memory T cells, so that if you ever then come in contact with that particular bug, your immune system's already primed to go. And then the killer cells, so they're the ones that can get in there and directly attack the foreign body. B cells work in a completely different way. So B cells form a part of the humoral immunity. And the way that they perform their immune function is by making antibodies. Antibodies are little proteins that are critical in helping protect against infection. And these other things called cytokines. Cytokines are more like chemicals. So again, that play a critical role in actually attacking and directly destroying foreign bodies, including lymphomas potentially. Now, T cells can be utilised in a number of ways. You can harness their potential and use them in the treatment for diseases. And these are three different ways that we can do that. One is these biospecific antibodies, so they're like monoclonal antibodies with something additional. These immune checkpoint inhibitors, and then finally CAR T cells. So biospecific antibodies are called BITE antibodies, which stands for Biospecific T Cell Enhancer Antibodies. Now, they work in a similar mechanism to the monoclonal antibodies like MabThera, in that one part of the antibody binds to the immune system, another part of the antibody binds to the tumour cell. But they have a third bit to them, and that third bit is that they have another part to them that binds T cells. And what that then does, you end up with the tumour cell and a T cell being brought essentially into close proximity. So it's almost like being put into a boxing ring together. And so effectively it's a way of drawing the immune system to the point of where the tumour is. Now, one example of this is this drug called Ebenetuzumab. So we've actually just recently finished participating in one of the clinical studies at the Royal Brisbane Hospital in patients with ALL, so acute lymphoblastic leukemia. So it's a type of lymphoid leukemia. And this is, again, a group of patients who'd been through standard treatments, things like donor transplants, and had subsequently relapsed. On the whole, had no other treatment options. In this particular drug, there was about a 75 to 80% response rate to the use of the Ebenetuzumab by itself. It's an inconvenient treatment because it's 28 consecutive days of infusion. But that can be done as an outpatient, but it does mean you need to have central lines and be permanently on a device. Now, the way that it worked is by having one part of it bind to CD19, so that's a protein found on B cells, so it's found on the leukemia cells, and then CD3 is a protein that's found on T cells. So basically it was drawing the T cells up against the leukemia cells. Now, why this is important is we're now starting on similar studies in a range of lymphomas. So there's a diffuse large cell lymphoma study about to start at the Royal Brisbane Hospital, and there's other studies elsewhere looking at this treatment in follicular lymphoma. And again, using it's the same concept. So CD19 is found on B cells, and then CD3 on T cells. So expectations would be very high, but this may be a very promising treatment. Difficult thing again, prohibitively expensive. It's probably several $100,000 for a treatment course at the moment. So again, getting it routinely funded is going to be a challenge. So these, I mentioned before about checkpoint inhibitors, so immune checkpoint inhibitors and the current availability of those treatments in the use of melanoma and in people with forms of non-small cell lung cancer. So our immune systems are clever things. They have this thing called an immune checkpoint. Many of you probably might use two-factor authentication for signing into websites or signing into your bank. So where you type in a password onto the website and then it sends a message to your phone which gives you a 6-digit PIN number that you then have to type in. So it's a checks and balance to make sure that is actually the right person who's checking into the bank website. Our immune system is similar. It has various checks and balances in place. And these immune checkpoints are one of those. There's a number of different checkpoint inhibitors that are out there. Nivolumab and pembrolizumab have some very important early evidence in the treatment of Hodgkin's lymphoma that looks very exciting. But those are the two drugs that are now available for melanoma. And again, if you think about melanoma, it's a disease that has, for patients where it spreads beyond the skin, a terrible, terrible outcome most of the time. And it's not responsive to chemotherapy. They don't respond to radiation treatment either. So there's been very little in the way of active treatments for that particular disease. So this has changed that. So that's the great thing about these particular treatments. And there's a number of other potential checkpoint, immune checkpoints that we can use in the treatment against various diseases. Now, what's important about these drugs is potentially they could be used in all types of cancer, because the thing that these drugs overcome is probably applicable in every type of malignancy known to man. So the response may be variable, but ultimately these are treatments that could have a role to play in most types of diseases that we look after. So this is an example of that immune checkpoint concept. So on the left-hand side is the T cell. So this is a T cell attacking a tumour cell. And it does that through this thing called the T cell receptor, or the TCR. So that T cell receptor binds to a protein on the outside of the tumour cell, and that then turns on the killing of that particular tumour cell. But the tumour cell uses an immune checkpoint to actually prevent that attack from working. So this thing called PDL1, or programmed death receptor ligand 1, which is found on the outside of the tumour cell, binds to a receptor on the T cell, and that disengages the immune response. So it's like that two-factor authentication we were talking about before, but in the opposite way. So when that binding occurs, the T cell can no longer kill the tumour cell. So the way that these checkpoint inhibitors actually function is by either blocking that PD-L1 receptor on the tumour cell, or by blocking the PD-1 receptor on the T cell, so that this checkpoint inhibition gets switched off and the T cell can now exert its immune function against the tumour cell. And as I say, these tumours, lots of tumour cells have been demonstrated to escape immune surveillance using this very technique. So again, there's a lot of data on this slide, but if you look at the bottom curve, so this is people with refractory Hodgkin's lymphoma. Hodgkin's lymphoma most of the time is a disease for where frontline therapy will cure it, but around about 20% of patients will relapse and may relapse again after things like autologous transplants. And it's been an area of unmet need because that group of patients have had little in the way of go-to options. Brentuximab has been one example of a drug. Brentuximab works in a very different way, but Brentuximab has been very, very effective. But this was then looking at a group of patients, most of whom had also been through Brentuximab, and so therefore, again, had very little in the way to offer when these drugs came along. So the bars on the bottom represent individual patients, and 0 is the baseline, and the dotted line that you can see is a 50% response rate. Now what you can see is every patient is below the curve, or below the 0 point. So every single patient responded to this drug called nivolumab, which is one of these checkpoint inhibitors. So nobody progressed. Only 4 of the patients, and I think there were about 22 on this study, only 4 out of the 22 got less than a 50% response. and around about 5 or 6 patients got a complete response. So this is the worst possible group of patients with Hodgkin's because they've been through all these different treatments. Their disease is almost certainly going to have inherent resistances to a lot of treatment. So to get this degree of response for this drug as a single agent is quite extraordinary. And this is a similar trial that was done on a drug that binds to exactly the same pathway, just made by a different company called Pembrolizumab. And again, the top curve there is exactly the same. Now, there were a few patients, so 3 patients in this study that didn't respond to the Pembrolizumab, but once and again, you can see that most of the patients are below the line and quite dramatic responses. The same type of patient as well, so patients who'd been through multiple lines of therapy, including autologous transplants. Now, what was particularly impressive from this study is the slide on your left-hand side is the overall survival curve. So at approaching 2 years post-treatment, 78% of patients were still alive following on from Pembrolizumab. It's not 100%, so it's certainly not perfect. But you would have normally expected without this treatment that every single one of those patients would have succumbed to the complications of their disease. So, so very impressive. So both of these drugs, nivolumab and pembrolizumab, are about to go through the process of application to the government to consider funding. Once again, they're very expensive. They're also being moved forward in the treatment strategy. So there's trials starting now looking at these treatments as part of frontline therapy or as part of therapy for first relapse. There's also trials in various different types of lymphomas. Pretty much every subset of lymphoma, there is currently a trial somewhere in the world recruiting for these particular drugs. So what about transplants? Probably the main thing I do in life is I'm a stem cell transplanter. I hope one day to be able to say we never need to transplant anybody ever again because nobody ever gets these diseases in the first place. But transplants actually are critically dependent upon the immune system to do what they do, particularly donor transplants. So by way of explanation, autologous transplants are those circumstances where you get your stem cells back from yourself. So you've previously donated stem cells and then you get really intensive chemotherapy and you then get your stem cells back to rescue the bone marrow from that toxic dose of chemotherapy. Allogeneic transplants are where the transplanted stem cells come from somebody else. And that may be a sibling, it may be an unrelated donor, or very rarely it may be another member of the family who is not a sibling. And we have the occasional rare circumstance where somebody has an identical twin and they get used, and they're called syngeneic transplants. Now, allogeneic transplants are felt to cure lymphomas using this concept of the graft versus lymphoma effect. So when we transplant stem cells from a donor into the recipient, not only are we transplanting the stem cells, we're also transplanting that person's immune system into the recipient as well. And we then utilise that new immune system to attack and kill the lymphoma cells. So rather than trying to manipulate the person's original immune system, we're using somebody else's immune system. And with the optimism that that new immune system, that the lymphoma won't have a mechanism of escaping that new immune system. Now, the problem with donor transplants is that that new immune system can also do bad things. It can cause a process called graft versus host disease. So that's where that new immune system starts to attack the normal proteins on the recipient. And so having this balance between trying to control the graft versus host disease, but keeping the immune system unleashed enough to enable it to attack the lymphoma cells can be very challenging. So how do we know that this graft versus lymphoma effect actually occurs? Well, we know that in patients who get graft versus host disease, they have a lower risk of relapse. So that's telling us biologically that because that donor immune system is active, not only is it causing problems with the host, but it's also attacking the lymphoma cells. The important cells, again, are these T cells. So they're the cells that cause the graft versus lymphoma effect. Now, some transplants involve removing the T cells from the product that we give. And when you do that, the incidence of relapse goes up. So you can reduce the likelihood of getting the bad problem of graft versus host disease by removing the T cells, but you probably also remove the chances of actually getting a good cure. So that's indirect evidence. The direct evidence is that we can actually see somebody, for example, with follicular lymphoma after the transplant. And if we pull that person off immune suppression, or we give them T cells from the donor, we can actually see that lymphoma disappear in front of our eyes. So that's the direct evidence that the immune system can actually do this job of attacking and killing the lymphoma cells. And this is a graphical example of that. So this is somebody who underwent or was diagnosed with follicular lymphoma, went through treatment. The treatment didn't work very well, and round about April of 1995 actually underwent a donor transplant. And what this graph is actually measuring is a thing called 14-18 translocation, and that's the hallmark of follicular lymphoma. We can detect the presence of that abnormal protein. And just after the transplant, the levels went back up again, so the lymphoma started to relapse. And this person then received T cells from their donor, and you can see that the graph then plummets. So that 14-18 disappeared, and the patient remained in remission. So this is again the evidence that by giving T cells, by improving the immune response that the donor immune system can have, you can actually cure follicular lymphoma, despite the fact it was relapsing after the transplant. So the final thing I just want to talk about is this new concept. This is a platform that may be available in clinical trials in Australia in the next year or two. And it's a thing called chimeric antigen receptors. Now, you may remember that slide I was showing about the checkpoint inhibitors, where you had a T cell receptor that was binding to the protein on the tumour cell, and then you had that immune checkpoint down below that stopped that from working properly. What these things are, this is a way that in the laboratory you can engineer the T cell receptor. So basically you can take T cells, you can strip off their normal T cell receptor and place it with these things called CAR. And the way that that's done is basically by collecting T cells from the host and then using a technique called a retrovirus. A retrovirus has that CAR protein inside it, and then you insert that retrovirus into the T cells. This is all happening in the laboratory. And those T cells then take up that CAR, and that CAR replaces the normal T cell receptor. And then you reinfuse those back into the host. Now, what that CAR thing has already been done in the laboratory previously is that that CAR receptor only binds to one particular thing. And so you can choose what that thing is going to be. So, for example, for somebody with B-cell lymphomas, you could get that protein to bind to something like CD19 or CD20. And so when you inject those T cells back into the host, that's the only thing it will attack. So it can directly then attack lymphoma cells. You can do it for myeloid diseases, you can do it for a range of different tumours. So this CAR T cell technology is important because it's essentially using the same strategy we've been using for donor transplants, where you get a foreign immune system to do it. What we're doing here is taking the actual innate immune system of that person, manipulating it in a way that we actually can get it to direct the attack against the tumour cells. And there has been some data already published from the US groups. So again, there's a lot of data on this slide here, but the curve up in the very left-hand corner is another one of those response curves. So again, each of the individual bars is a patient. So this is a group of young kids with ALL, so acute lymphoblastic leukemia. ALL is a disease that's curable in 90% of kids with chemotherapy. So again, for the 10% who relapse after that chemotherapy, it can be difficult to keep them in remission. But this was using this particular technology with a CAR T cell against CD19. And you can see there that I think it was about 2/3 of the patients actually went into complete remission after the treatment. And they stayed that way. So, and again, all these kids had had things like donor transplants, various other forms of chemotherapy previously. So in this study, in fact, they were manipulating the donor's immune system with this CAR T cell technology, so getting the T cells in the donor. But it doesn't have to be that way. You can actually do it using the recipient immune system itself. So very impressive technology. Now, we're currently in the process at the Royal Brisbane of looking at setting up this platform ourselves. Because of the nature of the platform, it needs to go through very high-level regulatory requirements. So it's at least 18 months to 2 years away before it goes through TGA licensing and that. But realistically, we do believe this is a technique that may actually ultimately enable us to no longer have to do donor transplants. So escape that toxicity that comes from donor-type transplants. Okay, so that's really the end of the talk. So I think what I've tried to say today is that our immune systems are critically important in our overall goal of treating lymphomas. Our immune systems are critical for preventing lymphomas from happening in the first place, and anything that really prevents our immune system from attacking lymphomas is ultimately going to be important for those lymphomas actually developing them. But more importantly, what I believe is that we are going to be more able to harness the actual effects of the immune system and use that in the overall treatment strategy and hopefully cure more people with lymphoma. Okay, thank you.